all the delegates and the participants for this today's program and the online CMEs. First of all, I welcome from the MSN Laboratory on behalf of the group of the companies of Mr. Ashish Gupta. He is the Vice President on the domestic formulation. Mr. Sushant Jena, our Senior General Manager, Sales and Marketing. Mr. Nitin Chaturvedi. And I am Tanmay Mandal, Head of Marketing, is welcoming for everybody for this today's program. Sir, before I process for this today's program, I like to take the 2 minutes to introduce about the MSN Laboratory. Sir, innovation resonates a sense of purpose in the evolution and existence of human life. The creative capacity of a human line has always been the source of inspiration. We believe every life matters and everyone deserves a quality medicine. Apart from the efficacy, affordability, and accessibility, we want to be the first to touch and impact human life. We are MSN Research for Better Medicine. MSN Global Research Portfolio, MSN has the Asia's largest pharmaceutical research center, where we have 1,400 scientists, dedicated scientists who are working together. We have 17 plus branded generic we have launched in India, 42 scientific labs, and 2 pilot plants we have. 690 plus patent for API and formulation we have filed till now. We have advanced global approval for manufacturing site. 11 sites we have in India and 1 site we have in USA. We have 30 plus approval from various leading authorities like US FDA, EPMHRA, WHO, and many more. We have 300 plus bioequivalent formulation. We have 450 plus API we manufacture them. Our global presence, we are truly indigenous, having global reach. Our presence is there in 65 plus countries. We have filed 410 plus DMF filing we have done. 10 global offices we have, including US, UK, Colombia, and many more places. We have 2,000 plus dossier globally. Our cardiological innovation, to bridging the gap, we have launched various world first branded generic. In pulmonary arterial hypertension, we have launched ambrisentan, tanlofil, Rio Sugar, Nesitantan, and now it is Selexipag. In hyponatremia management, we have launched tolvaptan. In diabetic management, we have launched dapagliflozin. In antihypertensive, we have the azilsartan, that is Azilol. In antiplatelet, we have the Prasusafe, that is Prasugrel, Ticagrelor, that is TRA, and Cangrelor, that is Canreal. Our future product portfolio, we are constantly innovating and evolving, creating the reverse product for the reverse market across the globe. In heart failure management, we are planning ferric carboxymaltose. In antidiabetic, empagliflozin. In antidiabetic, also we have planning sitagliptin with metformin, linagliptin, based on the patent. To partner in creating awareness in the management of pulmonary arterial hypertension, approach for the emerging treatment option that to increase the patient life expectancy and quality of life. For that, this program, first I like to welcome for today's moderator and chairperson, Dr. B.K. Sastry. Dr. Sastry is working as a head in Department of Cardiology, Care Hospital, Hyderabad. His area of interest is in clinical research, especially in the pulmonary hypertension. Dr. Sastry has published the first randomized clinical trial of Selexipag 20 mg in the treatment of pulmonary arterial hypertension. And he is steering committee member of Selexipag trial also. Dr. Sastry worked as a principal investigator in other PS clinical trial also. He has more than 50 articles are published in national and international journal and more than 1,000 abstracts presented in national and international cardiology conferences. So I welcome Dr. Sastry for this today's program. Along with Dr. Sastry, I like to welcome for our today's speakers. First speaker, Dr. Rajadhar. Dr. Rajadhar is an active executive committee member of Indian Chest Society, has more than 46 articles are published in national and international journal. Currently, Dr. involved in 12 international and national research projects. Dr. Rajadhar worked as an examiner for MRCP, both for UK and India. Dr. Rajadhar is involved in coordination with the DNB courses for the last 3 years, and he is one of the who has started the first DNB course in West Bengal. I welcome Dr. Rajadhar for this program. Along with Dr. Rajadhar, I like to welcome for our next speaker, Dr. Prashant Bhopate. Dr. Prashant Bhopate, he is achieved the youngest investigator ever from the Mumbai person in the end stage of pulmonary hypertension. Dr. Prashant having 12 years of experience in diagnosis and management of patients with the CSD pulmonary hypertension. He pursued fellowship in pediatric cardiology, from Escort Heart Institute and Research Center, New Delhi, and Pulmonary Hypertension from Canada. He has more than 20 articles published in national and international journal and 6 chapters in textbooks of the pediatric cardiology, and pulmonary hypertension. So, after this, I'd like to welcome once again Dr. Sastry. Sir, now the dais is yours. I'll hand over the session to you.
Hello, good evening, everyone. Am I audible and my slides visible?
You are audible, your slides also visible, sir.
Okay, great. Good evening, everyone. First of all, I congratulate MSN for coming out with Selexipag. It is really the unmet need in pulmonary hypertension management. Literally, we have been waiting for years. And I was fortunate enough to participate in the pivotal Griffon study. I recruited about only half a dozen patients. I wish we could recruit more, but thanks to DCGI regulations in those times, we could not enroll many patients. It is really important that we have this molecule in the fight against pulmonary hypertension in this country. Now, my assignment is first I give a brief introduction about pulmonary hypertension from a cardiologist perspective. Then we move on to the Selexipag. Now, pulmonary hypertension is recently defined as the resting mean pulmonary artery pressure of more than 20 millimeters mercury measured during right heart catheterization. It is very important that this aspect is known because many times people just resort to echocardiogram and be happy with it. So, but it should be done ideally, definition-wise, by right heart catheterization, and you have to estimate mean arterial pressure, which is generally not possible to estimate accurately, precisely on echocardiography. Now, that being so, it is not you should understand, pulmonary hypertension is not a specific disease. It's a conglomeration of the diseases. It has it's a mere hemodynamic abnormality that portends to the underlying disease and often indicates advanced disease with poor prognosis. A presence of pulmonary hypertension, say in left heart failure, or pulmonary artery disease, pulmonary disease, parenchymal disease, generally means poor prognosis. It has got insidious onset, so difficult to pinpoint exactly the symptoms started. It's very subtle, non-specific symptoms, and they are very overlap with other diseases, so there is a delay in diagnosis. And because it's a rare disease, the low level of suspicion, and many other common diseases like simple anemia, asthma compete with the diagnosis. Because of that, there is a usually 2 to 3 years gap from the onset of symptoms to the diagnosis. And even in the advanced countries, in the major trials, nearly 60-70% of the patients present with advanced disease like class 3 or class 4. Oops. Now, what are the symptoms and signs? We have got dyspnea, fatigue, giddiness, syncope, which is very important. Exertional syncope in young woman or young man, you should look for and rule out pulmonary hypertension. Chest pain can be non-specific. Edema of feet generally occurs in late stages, including right upper quadrant pain. A loud P2 will be almost always obvious. Elevated JVP, pansystolic murmur, tender hepatomegaly, they're all signs of right heart failure, which means that the disease is pretty advanced. Don't wait for the patient to develop right heart failure to diagnose pulmonary arterial hypertension. One word of caution, if you've got a wide pulse pressure and ejection systolic murmur, they are not features of pulmonary hypertension. And pulmonary hypertension being hypertension, there are different compartments in the pulmonary vasculature. The pulmonary artery divides into capillaries, and capillaries again form pulmonary veins, and pulmonary veins reflect the left atrial pressure. So problems in the cardiovascular system, anywhere from the left ventricle to the mitral valve, left atrium, they have a backward transmission, and there can be a post-capillary pulmonary hypertension typically seen in the left heart disease, or there can be a pulmonary disease, vascular disease confined to the precapillary, that is called precapillary, and sometimes combination is there. So what is precapillary pulmonary hypertension? In all these 3 pulmonary hypertension compartments, the mean pulmonary artery pressure is more than 20 millimeters. If it is precapillary, the pulmonary veins and the left atrium is not involved, so pulmonary artery pressure is less than 15 and vascular resistance is more than 3 units. Isolated post-capillary pulmonary hypertension, typically what we have learned in mitral stenosis or left heart disease, with a systolic or diastolic failure, we have again got a mean pulmonary artery more than 20 millimeters. Pulmonary artery wedge pressure is more than 15 millimeters because it is reflecting the left atrial pressure, and pulmonary vascular resistance tends to be less than 3 Wood units. However, if the left heart disease is present for a long time, or typically in heart failure with preserved ejection fraction, we see mean pulmonary artery pressure more than 20 millimeters. Pulmonary artery wedge pressure is again more than 15 millimeters, and PVR is more than 3 Wood units. So these are some of the hemodynamic concepts we should understand while treating or managing pulmonary hypertension. Now, based on the etiopathogenesis, natural history, pathobiology, and response to treatment, and so on and so forth, WHO task force has classified pulmonary hypertension. I told you is a hemodynamic abnormality. It's not a one disease. So all these are the diseases which cause pulmonary hypertension, and these diseases are classified based on the criteria I mentioned to 5 groups. The first group includes all these idiopathic, heritable, drug and toxin related. They're all group 1. Group 2 basically means left heart disease. Group 3 basically means pulmonary disease or hypoxia because of any kind. And WHO group 4 is the occlusion to the pulmonary vasculature, typically with the thromboemboli, sometimes with the malignant regions or some other problems. Then group 5 is a group of miscellaneous or multifactorial disorders, including hematological disorders, systemic disorders, storage disorders like sarcoidosis, Langerhans cell granular, inflammatory diseases like sarcoidosis, metabolic disorders like Gaucher's and other diseases. We are concerned, when you say pulmonary arterial hypertension, we are confined to this group we see in the red box. When we say pulmonary hypertension, these are all the groups of diseases are involved. Pulmonary arterial hypertension refers to group 1 diseases. Now, among the pulmonary arterial hypertension, both French and Reveal registry show that it may be idiopathic pulmonary arterial hypertension, familial, drug or toxin related, connective tissue disease related, portal hypertension, and HIV related, congenital heart disease, operated or inoperated shunts, and other miscellaneous. So the distribution now is more or less same both in the French and US, but unfortunately we don't have this kind of a registry in this country. And the incidence cases are approximately 2.3 to 2.4 abroad, probably the same being a biological disease. And prevalence is about 12 to 15, and there is a female predominance. In the TCG, I'll not take much time. There is a right axis deviation, right atrial enlargement, right ventricular hypertrophy, and strain pattern are commonly seen, but sometimes ECG can be normal. Echo is important. The moment you think of pulmonary hypertension, do an echo. If you look for pulmonary hypertension, and if it is a high probability, then simultaneously look for left heart disease or valvular heart disease on echocardiogram. If the suspicion is low, then you proceed to think of other diagnoses. How do you estimate the right ventricular pressure? As I told you, we can't estimate the mean pressure easily. We have methods, but they are not reliable. It's easy to estimate the systolic pressure, RV systolic pressure. In the absence of pulmonary stenosis, RV systolic pressure is equal to pulmonary artery systolic pressure. You estimate by Bernoulli's equation tricuspid regurgitation velocity that gives the pressure difference between the right ventricle and right atrium. And you add to that the estimated right atrial pressure, you get the right ventricular systolic pressure, which is equal to pulmonary artery systolic pressure. These are the other evidences of the pulmonary arterial hypertension. We have got ARIA-RV dilatation. We have got the D-shaped left ventricle, and there is an acceleration time, or the time from the onset to the peak of the pulmonary waveform is on Doppler is short, less than 105 milliseconds. There's typically a pulmonary Doppler notch is there, mid-systolic notch. From the pulmonary arterial diastolic pressure, you estimate the diastolic pressures. And right atrial volume is important more than area. Right atrial area is important more than 18 centimeters square, indicates generally onset of right heart failure and severe PAH. Inferior vena cava diameter gives estimation of right atrial pressure. And this is from the American Society of Echocardiography. These criteria, if the pressure is more than tricuspid regurgitant velocity is more than 3.5, you know for sure it is pulmonary hypertension. If it is between 2.9 to 3.4, if you have got the previous signs that I mentioned, then there is a high possibility that this is pulmonary hypertension. Suppose the pulmonary tricuspid regurgitation systolic velocity is less than 2.8 are not measurable, you can't be certain and the probability is low. Between 2.8 to 3.4, depending on the presence or absence of the pulmonary hypertension signs, one can say it's intermediate. So many times I see, based on the tricuspid regurgitation velocity, many echocardiographers and physicians tend to diagnose pulmonary hypertension, which is not necessarily accurate. The most important thing I want to emphasize, the people, cardiologists especially, unfortunately, the people who do echocardiography, And many people are happy giving right ventricular systolic pressure. That is not sufficient. If you are managing or following a patient of pulmonary hypertension, please follow the right ventricular function, assess the right ventricular function. That is very important. There are people who do regularly echocardiography. I'm sure they would know. These are the parameters they should incorporate in the echocardiographic report. May not be required in routine patients, but when you have got a patient with pulmonary hypertension, they should comment on these parameters, and they are important for follow-up. Right heart catheterization, till today in this country where cardiologists are doing, this is important to clink the diagnosis or confirm the diagnosis of pulmonary hypertension. From the jugular vein, preferably you pass a Swan-Ganz catheter, you estimate the right atrial pressure. You see here, you go into the right ventricle, this is the right ventricular systole, the waveform, then you balloon flotation catheter goes into pulmonary artery. You have the pulmonary artery systolic diastolic mean pressures, and you wedge it and you get the pulmonary artery wedge pressure. As for the criteria I mentioned in the past, you make a diagnosis of pre-capillary, post-capillary, or combined pre and post-capillary. Once you make a diagnosis of pulmonary hypertension, the second step is you do a ventilation perfusion scan, and if it is positive, or many people in this country do CT pulmonary angiogram, rule out group 4 pulmonary hypertension, that is thromboembolic pulmonary hypertension, because the treatment there is surgery. So you simultaneously rule out, because by the time you do echocardiogram, most of the time you have ruled out left heart disease. Now then, once you confirm all these things, suppose you come to there is no group 4 pulmonary hypertension, and you have ruled out lung disease based on the clinical and pulmonary function tests, and you make sure it is the pre-capillary pulmonary hypertension, then you do a congenital testing like for connective tissue disease or history of drug toxins or HIV, congenital heart disease, portopulmonary, etc. Based on the findings you do. This time doesn't permit me to go into all this. Now, what are the drugs? There are 3 pathways we use. Endothelin pathway. Endothelin is a potent vasoconstrictor. Endothelin antagonists like bosentan, macitentan, ambrisentan are already in use. Then we have got nitric oxide pathway. Here we use sildenafil, riociguat, tadalafil. These are already in use. What we don't have till now in this country is the prostaglandin pathway. In the prostaglandin pathway, we have got the prostaglandin analogs like epoprostenol, treprostinil, iloprost. Fortunately or unfortunately, they are not available in the country, so we will not bother about it. The prostaglandins, they convert the ATP to cyclic AMP, which is a vasodilator, and Selexipag is a prostaglandin receptor analog. It stimulates. So the ATP more cyclic AMP is produced and causes vasodilatation. This is the drug which we are going to talk about today. So as I mentioned, all these drugs are available. They can be given orally, all these drugs. The prostanoid analogs, treprostinil, epoprostenol, inhaled elaprost, are not available in this country. So we don't have to learn so much about them now. But today we will concentrate about the recent arrival in this country, Selexipag. Now, what are the drugs indications? If you see here, for class 2 and class 3 patients, the ambrisentan and the ambrisentan, these you can see here, functional class 2 and class 3. All these drugs, oral drugs, are indicated for class 3 and class 2 and class 3, whereas for functional class, none of these medicines is really indicated except intravenous epoprostenol. So for class 4 patients, we can use these drugs, but you can't really expect great result because we have no choice to use them. But if people have choice, they should go for epoprostenol. But here, all these drugs, ambrisentan, bosentan, macitentan, PDE5 inhibitors, endothelin receptor antagonists, and Selexipag, they come under class 1 indication for functional class 2 and 3, and the level of evidence is B. Now, so when you have encounter a patient with pulmonary hypertension, estimate whether the patient belongs to first assess vasoreactivity, and if it is vasoreactive, patient goes on to calcium channel blockers. If he is not vasoreactive, estimate whether the low or high risk. If it is low risk patient, class 2 or class 3, you start with initial oral drugs. Generally, nowadays, it's advised to give combination of endothelin receptor antagonists and PDE5 inhibitors. Then wait for 3-4 months. I'll be telling you how to assess the severity. If the severity is more, you switch on to the higher end drugs. In the absence of epoprostenol, we go for lung transplant or atrial septostomy. General supportive measures are indicated in all these patients like diuretics, oxygen, digoxin, anticoagulants. And important thing is ACE inhibitors, beta blockers are not indicated in these patients, and they can be harmful. And general supportive measures like counseling about pregnancy, immunization, social support, all these things are recommended. You should know pulmonary hypertension in general, appearance of pulmonary hypertension has a poor prognosis and the patients tend to do worse. irrespective of whether they have got cardiopulmonary disease, whether reduced LV function or preserved LV function. As the time goes, the present pulmonary hypertension, pulmonary vascular resistance increases, the pulmonary artery pressure increases, but as the right ventricle fails, the cardiac output decreases and pulmonary artery systolic pressure decreases. So if you are measuring the pulmonary artery pressure, if you are assessing the pulmonary artery pressure hypertension only by RV systolic pressure, at this point, a failing ventricle cannot generate pressure and the pulmonary pressure comes down. You should not have the false belief that the patient is improving. Please assess the right ventricular function. And if the right ventricular function is worsening, the patient is not doing well. So as I mentioned, the pulmonary vascular resistance progressively increases. We want to alter the trajectory of this deterioration by giving the pulmonary vasodilators. And if you give early, the trajectory will take off here. If you give late, the trajectory will continue here. Once the right ventricular dysfunction or right heart failure sets in, patient doesn't do well. So you still give pulmonary vasodilators, but you can't really expect much benefit. This is very important while monitoring the patients. You should understand whether the patient belongs to low risk, intermediate risk, or high risk. And you can assess by history symptoms, whether functional class, history of syncope is there or not. You should do a 6-minute walk test, and based on that, you assess. And if you have got cardiopulmonary exercise testing, NT-proBNP is one of the useful modalities. You should assess the right atrial area and look for pericardial effusion or RV function assessment. Hemodynamics, if you can do frequently, you can do a right atrial pressure of less than 8 or cardiac index or mixed venous oxygen saturation. They're all the parameters which will tell you how the patient is progressing. Clinically or in our setup, we can do symptom assessment, syncopal history, functional class, 6-minute walk distance, NT-proBNP, and imaging. Except hemodynamics, you can get most of the information, and the low risk patient has a mortality of less than 5% per year, intermediate 5 to 10, and high risk more than 10. The whole idea of treating this pulmonary hypertension is to bring the patient to low risk or intermediate risk, if not from high risk. So for that purpose, once you give all these pulmonary vasodilators, and before the patient deteriorates into class 4, class 3, class 4, you should give these patients the medication. And for that, you should understand what is the functional class, monitor 6-minute walk test, look at the NT-proBNP levels of the RV function. Before the patient slips into high risk category, start these pulmonary vasodilators, including Selexipag. Now, coming to Selexipag, this is one of the pivotal studies published in NEJM in 2015. In this large study, which included 1,156 patients followed for 4.3 years, it is a phase 3 multi-center study, randomized double-blind control study. Unlike other pulmonary hypertension studies, it is an event-driven study. The morbidity and mortality are the endpoints. I'll explain to you what it is. And the primary outcome is time to first adjudicated morbidity and mortality event up to 7 days after the last study drug intake. So it is the patient has, what are the morbidity and mortality events? Before that, I'll tell you who are the patients being studied. Whenever you see a clinical study, you should know who are the patients in which the drug has been or intervention has been studied. These patients are wide age group, 18 to 75 years. Here, idiopathic or group 1 pulmonary hypertension. This is very important. I mentioned in the first red box in one of the slides. Group 1 pulmonary hypertension. This is not applicable to group 2, group 3, group 4, group 5. The group 1 patients are idiopathic or heritable pulmonary hypertension. Pulmonary hypertension due to HIV or due to toxin exposure or connective tissue disease or repaired congenital systemic to pulmonary stents. And in this, as being a research study, the confirmation has to be done by right heart catheterization. So if you look at the baseline characters, most of these patients have 50% have nearly class 1 or 2, and class 2 or class 3, 4 are approximately 50%. Only a small percentage are in class 4, though it says class 4, I think 1% or so on the class 4. The second point is some of them are drug naive, like 21%, but most of them are either in monotherapy or dual therapy. So patients who have already been taking pulmonary vasodilators. So what is the endpoint? Morbidity or mortality. So all-cause death. What is morbidity? You assess by disease progression, or if the patient is hospitalized for worsening heart failure, pulmonary hypertension, or if you think the clinician thinks the patient is too sick and requires continuous oxygen therapy or intravenous prostaglandins in the countries where it's available, or if the physician thinks the patient has become too sick that he requires a lung transplantation or atrial septicemia. So how do you objectively assess the disease progression? Sorry. There should be a worsening of the function class, and 6-minute walk test has to deteriorate by 15%. So this is one of the very good endpoints of a clinical trial, clinically relevant. And how do you give this drug? The drug comes in 200 micrograms. it has to be started twice a day. After 1 week, you make it 400 micrograms. Then weekly intervals, you go from 200, 600, 1000 up to a maximum dose of 1600 micrograms. Why is this? I'll come to you. This is a little nasty drug because it produces a lot of side effects. We'll come to it. So because to allow the patient to tolerate this drug and understand the side effects, we give the patient as much dose as he tolerates. Suppose you start with 200, he tolerates, you go to 400, he tolerates, 600, he tolerates, 800, he doesn't tolerate, then you go back to 600. So every week you increase by every week or 2 weeks in clinical practice, you increase by 200 micrograms increment. Then you give the maximum dose that he can't tolerate. Then you come down to the threshold dose, the maximum dose he can, you go increase up to the threshold dose where he can't tolerate and come down, de-escalate to a maximum dose that he can tolerate. So when the studies run like this, so many patients, so many percent, nearly 15% tolerated 200 mg BD, only 59% tolerate about 400, like this. There are good number of 30-40% of the patients they tolerated maximum 1600 BD. So it's not that all the patients have one dose. The dose for each patient varies depending on his tolerance levels, which can vary from 200 to 1600. So in each patient, you have to investigate and discover the dose, the maximum dose that he can tolerate. So when the study was done like this, Selexipag has a huge advantage over placebo, nearly 40% reduction in the morbidity mortality event. AR ratio is 0.60 with narrow confidence intervals and p-value less than 0.0001. And this advantage is seen even on the top of patients who have been receiving endothelin receptor antagonists and PDE5 inhibitors, nearly 37% risk reduction. So there is it's not just an increment or marginal increment, it's a significant increment. So when they did the sensitivity analysis, background therapy did not affect. So whether the patient is on dual therapy or single monotherapy or no therapy, the benefit, because this here is on the to the left of the median, here the benefit is clearly seen in these patients who have taken Selexipag. And whether the patient has tolerated only low dose, medium dose, or high dose, the benefit is same. This does not mean that you stop with low dose. Here we gave the dose, the maximum tolerated dose. So maximum tolerated dose may be 200 or 1600. Whenever you give the maximum tolerated dose, the maximum benefit is there. Now, what are the side effects? The side effects are there both in this one. The significant serious adverse events are more in the placebo group, whereas the reason for discontinuation because side effects is more in the Selexipag group. Otherwise, most of these things, worsening of the disease, side effects due to worsening of different disease because of pH worsening, right heart failure, syncope, etc., are more in the placebo group. The placebo group discontinuation is because of the adverse events, whereas the placebo, it is 7.1, it is 14 in the Selexipag group, whereas the side effects are more or less same in other side effects are not significant. So what are the prostaglandin specific side effects which I have been talking about? The prostaglandins as a group cause some side effects. What are these? Headache, pain in the jaw, diarrhea, nausea, flushing, pain in extremities, body aches, myalgias, arthralgias. These tend to decrease over a period of time. So you treat them symptomatically. That's why you gradually escalate the dose. Suppose somebody is having headache, pain, jaw, you counsel them, you advise them, give some simple analgesics like paracetamol. If somebody has diarrhea, you can give some bowel mobility restricting agents. So advise the patient, reassure the patient. Gradually they tolerate. As the patient tolerates, you escalate the dose. So in conclusion, Selexipag significantly reduced morbidity mortality. Individual titration to the highest tolerated dose is resulted in consistent efficacy. It is generally well tolerated with no safety concerns over long period of time. Now, expert panel has tried to give a consensus statement about where to use this drug. These slides are really little bit confusing, but what I would say in nutshell, if the patient is worsening functional class 2 and functional class 3, but not going into functional class 4, they have given some 13 or 14 recommendations, which are superfluous in country. Because these recommendations are in a setup where they have got access to epoprostenol, intravenous contrast, intravenous epoprostenol at treprostinil, or lung transplantation can be done. But in our setup, they really doesn't matter whether functional class 3 or 4 you have to give. If the patient is in functional class 2 worsening, then go ahead and start these drugs. So the take-home message from my talk PH is a disease of cardiopulmonary unit affecting pulmonary artery venous circulation. It's underdiagnosed disease globally, not only in India. Although the prognosis of PH has improved with targeted therapies, the outcome is dependent on early detection and accurate diagnosis. I mentioned you change the trajectory of the disease deterioration. The past 2 decades have brought remarkable advance in the treatment of disease treatment options. The target pathways implicated in PH pathogenesis, namely prostacyclin, nitric oxide, endothelin pathways are there. Now we have got prostacyclin pathway, Selexipag, nitric oxide pathway. We have got PD5 inhibitors and the Receptor and endothelin pathway blockers with ambrisentan, bosentan, and macitentan. The current practice guidelines for the treatment of PH propose a treatment algorithm according to patient risk factor. I mentioned to you low risk, medium risk, high risk. Patient considered lower risk based on clinical assessment can initially be treated with oral agents, whereas high risk patients, including class 4, should receive intravenous prostacyclin. Because we don't have intravenous prostacyclin, we have to continue with whatever we have got. Selexipag is a non-prostanoid agent, agonist in selective for IP receptor and mediates vasodilatation, I mentioned. Selexipag reduces the risk of morbidity mortality event by 40%. Selexipag may have better side effect profile than other oral prostanoids. We are not discussed about other oral prostanoids, which are not available in the country, but I take it from me, Selexipag is better than them. Thank you very much. With this, I close my talk. Maybe I think probably Prashant will take or Rajadhar will take.
Radha sir is going to take, sir.
Yeah.
Thank you very much. Dr. Shastri, if you could unshare your slides. Thank you. Thank you very much. So great talk. Thank you, Dr. Shastri, for setting the context. You've made my job easy. So next 15 minutes, I'll talk about group 3, pulmonary hypertension, and the management and context setting for Selexipag. So one conflict of interest statement, these slides have been created by MSN and they have been given to me by Amit and the team, and I'm thankful to them. However, the content of the slides and what I'm going to say over the next 15 minutes are a part of my thought process and my understanding of the subject. So this is what Dr. Shastri showed you. This is the 6th World Symposium on Pulmonary Hypertension classification. And you heard about the 5 classes that he so eloquently described. We are interested at the moment in class 3, which is to do with lung disease and or hypoxia. So lung disease leading to hypoxia, with hypoxia being the driving factor for the development of pulmonary hypertension. And when we talk about this, we talk about various classes of lung disease, which you see on the slide in front of you. So it could be in the form of obstructive or restrictive lung diseases. There could be the overlap pattern. There could be hypoxia from other causes. So people living in high altitude, people who have obstructive sleep apnea, for instance, have an overlap and also get classed in group 3 pulmonary hypertension. And then lastly, this developmental lung disease. So what I'm going to do is to concentrate on this particular group and talk to you about treatment with a specific focus about speaking about the prostacyclin analog, Selexipag. So think about the potential mechanism of development of pulmonary hypertension in patients with COPD. And I want you to think of this in 2 different scenarios. One is you have loss of lung function, you have hypoxia as the driving factor, and you develop pulmonary hypertension as a result of COPD. In most of these cases, the COPD is severe. You have an FEV1 impairment, which is significant, and this results in hypoxia, which results in mild to moderate pulmonary hypertension. So I emphasize again, this is mild to moderate pulmonary hypertension. In this group of patients, which is the vast majority of patients with COPD, the pulmonary hypertension will be mostly mild, with a few patients having moderate pulmonary hypertension. The second class of patients, which is probably the lesser number, but of greater interest for the audience today, is the group of patients where COPD and pulmonary hypertension coexist. some of these patients have pulmonary vasculitis, maybe inflammation driven. Maybe the underlying inflammation in this group of patients is the COPD underlying. However, these people have what has been described as disproportionate pulmonary hypertension. And this is important to understand. What that means is that even if you have mild to moderate pulmonary hypertension, these patients are breathless on movement, they are hypoxic on movement, they would desaturate on the 6-minute walk test that Dr. Shastri described. And these patients are found to have a pulmonary hypertension which is severe, disproportionate, and hence not commensurate with the lung function impairment that these patients with COPD have. So this is the class of patients which might benefit from the management, from the separate treatment of their pulmonary hypertension. And I'll talk about this a little bit more as I go along in this talk. So this has been described to you already. This is the classification of pulmonary hypertension, and this is in context with COPD now, the class 3 COPD that I talked about. So the first group of patients is COPD without pulmonary hypertension, which is a significant number of patients that you see with COPD. And here, the mean pulmonary artery pressure is less than 21. In most cases, if you look at the new classification, less than 15. The mean pulmonary artery pressure might be a bit higher, 21 to 24, but with the pulmonary vascular resistance being less than 3 Woods unit. The second group of patients is the one I described in the previous slide. These are a majority of patients with COPD with pulmonary hypertension, where the mean pulmonary artery pressure is between 21 to 24 millimeters of mercury, with the pulmonary vascular resistance which is raised, or a mean pulmonary artery pressure just above 25, so between 25 to 34 millimeters of mercury. And the third group of patients, which is a minority, but which was again on the previous slide, which is a pulmonary artery pressure of more than 35 or a pulmonary artery pressure of more than 25 with a cardiac index of less than 2 liters per minute per meter square. So this group is what I described as disproportionate pulmonary hypertension. So this slide talks about the various mechanisms which might increase pulmonary vascular resistance in patients with COPD. And you see a list on there. I'm not going to read through that list, but let's look at the highlights on that slide. So the first is airflow limitation. So greater the airflow limitation, greater the pressure swings within the thorax or within the pleural cavity. The second cause is emphysema. Greater the emphysema, greater the destruction of the alveolo-capillary membrane between the individual alveoli. This results in reduction of the vascular bed, which is embedded between the alveoli. We talked about hypoxia being the driving factor for pulmonary vascular resistance being increased. Acidosis and hypercapnia results in vasoconstriction, which again increases pulmonary vascular resistance and pressures. Hyperviscosity and polycythemia driven by hypoxia causes the same. And then we talked about spillage of inflammation within the lung due to COPD, resulting in remodeling, including fibrosis of the endothelium and the vascular bed. So those are hypothetical causes. Not all of these factors will be present in each individual patient. However, there'll be overlap, and these contributing factors is what increases pulmonary vascular resistance in patients with COPD. This is an autopsy study which looks at the pulmonary muscular artery in a patient with COPD. And I want you to look at, I'm not a pathologist, I won't be able to describe this to you in any great detail, but I want you to look at 2 different factors. The first is the inflammation, which causes a proliferation of the smooth muscle cells within the arterial intima. And the second is the deposition of elastic fibers in the intimal layer. So you can think of a vessel which is becoming thicker and has elastin deposition, which results in impairment of constriction of the artery, which you would normally get in patients who are hypoxic, in patients who are hypercapnic. So what are the factors that you need to look at before you say, this is your patient with COPD, who has disproportionate pulmonary hypertension? So common sense mandates that you need to exclude the other causes of pulmonary hypertension that might coexist within a patient with COPD. And these are the investigations that you need to think about. You need to exclude other causes of pulmonary hypertension. So for instance, you would need to do a CT angiography, a CT pulmonary angiography, or a VQ scan to make sure that your patient does not have chronic thromboembolic disease. Prashant will talk about heart disease and pulmonary hypertension. So you need to make sure that there's no left heart disease, which has caused right heart disease and hence pulmonary hypertension. OSA is an important factor, which is an overlap with COPD in plenty of patients. And that's something that we need to exclude. We need to look at risk factors for PH. HIV infection is an important factor that you need to exclude. The BMPR2 mutation is an important factor for pulmonary hypertension. And there's a list after that. You need to do pulmonary function testing to see whether there's overlap issues with COPD. You need to do imaging studies, right heart cath. So this is the list which helps in assessment of the pulmonary vascular phenotype in patients with COPD. And then when you prognosticate the way Dr. Shastri spoke about, you would do circulating biomarkers. The cardiopulmonary exercise testing has parameters which helps you to prognosticate in patients with pulmonary hypertension. This is an important slide. And if there's one slide from my talk that I want you guys to remember, it's this slide. So the first group, which I described before, is your patient of COPD without pulmonary hypertension. These patients, now look at the table at the bottom. So these are patients who have a low FEV1, a low or a normal DLCO, who have 6-minute walk test, which is reduced with desaturation, a PO2, which might be normal or reduced, and a pulmonary hemodynamics, which does not show pulmonary hypertension. So that's one of the commoner COPD phenotypes without pulmonary hypertension. The second group, which is a smaller group, but does exist, is COPD with post-capillary pulmonary hypertension. That's the yellow zone where the arm of the clock lies. And again, this is similar, a lowered FEV1, a mildly lowered DLCO, a 6-minute walk test, which is lowered, a PO2, which is lowered, and a mean pulmonary artery pressure, which is slightly more than the first group. Then you have the biggest group. That's your group with proportionate mild to moderate pulmonary hypertension. So here you have impairment of FEV1, a reduction of DLCO, you have a 6-minute walk test, which is significantly reduced with desaturation. The PaO2 is reduced in various ranges. So that's a majority of patients. It's proportionate, mild to moderate pulmonary hypertension. And then the group of interest for the talk today, which is the pulmonary vascular phenotype, where the FEV1 is reduced. The DLCO is reduced from two causes. The first is the COPD. The second is the disproportionate pulmonary hypertension. So it's a double whammy, which results in a double reduction of the DLCO. The 6-minute walk test is impaired. There is desaturation, but this is more a contribution of the ventilatory and the perfusion factors rather than just the ventilatory factors. So group 3 and group 4 are the ones worth remembering. So this is, again, something that you saw a little while ago. Dr. Shastri showed this and described this very nicely. This is a patient with pulmonary hypertension who has a vasoreactivity test done post a cardiac catheterization. A small minority of patients, 5 to 10% of patients today would be vasoreactive and would respond to a calcium channel blocker monotherapy. These patients have a far better prognosis as compared to the remaining 90% of patients who are non-vasoreactive. And then in the non-vasoreactive group, you have patients who have low to moderate risk. And then you have a group which is high risk. The low to moderate risk would be treated by an endothelial receptor antagonist plus a phosphodiesterase 5 inhibitor. Hence, the combinations such as ambrisentan and tadalafil, macitentan and sildenafil would be relevant in this group of patients. Along with this, if there's a third drug that needs to be added in, Selexipag could come in there as Dr. Shastri described in his talk. The other drugs that can be described in there, that can be considered in this group are Riosigat and Busantan. And then you have the high-risk group where your initial therapy would be parenteral prostacyclins like epoprostenol. And in addition to that, you can have an endothelin receptor antagonist, a phosphodiesterase 5 inhibitor, etc. And that's the class of patients who would be referred for a lung or a heart-lung transplantation. So it's mostly a heart-lung rather than lung transplant, as it shows in this slide. And that's a small minority of a group of patients, but these patients uniformly do badly with a poor prognosis. So those are the three signaling pathways that we have described just now: the endothelin pathway, the nitric oxide pathway, and the prostacyclin pathway. You heard that the prostacyclin pathway has drugs like Selexipag. They have just gone off patent, and we will hopefully have Selexipag and other prostacyclin analogs in the market in India for all of us to use for our patients with pulmonary hypertension. So what's the need for therapy in COPD with pulmonary hypertension? And that's a very worded slide. It's got lots of words in it. I don't want you to read this slide. I'll give you the highlights of the 3 points that there are on that particular slide. So we understand that patients have endothelial dysfunction, and this has an important role to play in pulmonary hypertension and COPD. The pulmonary hypertension in most of these patients is secondary to the chronic parenchymal lung disease that these patients have, and that's mild to moderate disease. There have been trials which have looked at treating these patients with pulmonary hypertension reducing drugs. One study quoted in there was with bosentan, which was given to patients with severe and very severe disease. Hypoxia at rest is what describes very severe disease. And these patients, on being given bosentan, had worsening hypoxia with increased mortality in this non-randomized study. There was another observational study which showed exactly the opposite results. So it showed significant functional improvement in GOLD 3 COPD patients and GOLD 4 COPD patients. But you understand this is more anecdotal evidence rather than the randomized controlled study all of us are normally used to. The use of sildenafil and iloprost in similar patients does result in hemodynamic improvement, but there's no significant clinical benefit. In fact, some of these small studies have shown worsening hypoxia. So bottom line on that slide, use of pulmonary hypertension lowering drugs in COPD needs to be done with utmost caution. If you use it in your patients with mild to moderate pulmonary hypertension, you can actually end up causing worsening hypoxia, greater mortality, and hence a lot of caution needs to be adopted before the use of these drugs. This looks at the titration dose scheme for Selexipag, and I'll sort of finish in the next 2 to 3 minutes because these are things which you will hear again in the next talk. But starting dose of 200, increasing dose by 200 microgram twice daily at weekly intervals till you reach the ceiling dose, which is 1600 micrograms twice daily. Hepatic impairment is what you need to remember and look out for. So this is describing a multi-center phase 2 double-blind placebo-controlled trial, so robust trial, 17-week duration, which looked at patients above the age of 18 with idiopathic or familial CTD-related congenital or anorexogenic use-related pulmonary hypertension, 12 weeks of background treatment with PDE5 inhibitor and endothelial receptor antagonists. The baseline right heart catheter showed increased pulmonary vascular resistance and a 6-minute walk distance, which was between 150 and 500 meters. And bottom line was that at by week 17, the pulmonary vascular resistance had decreased by more than 30% in the group which was given Selexipag. So a significant improvement in pulmonary vascular resistance. The other important factor of this phase 2 study was that the drug was well tolerated. The safety profile was as expected according to the pharmacological effect of the drug. So this talks about efficacy pearls of Selexipag. And I think 2 important things that are important to remember here is that the treatment effect is driven by differences in disease progression and hospitalization. So reduced hospitalization in the group of patients using Selexipag, and the addition of Selexipag to the ERA and the PDE5 receptor antagonists resulted in benefit and overall improvement in 6-minute walk distance in the group of patients using Selexipag. This is another trial which looked at the role of Selexipag in COPD. And the fourth group of patients we described, which is disproportionate pulmonary hypertension. Small number of patients, 6 patients in total. However, it showed an improvement in 6-minute walk distance in 5 out of the 6 patients. The mean pulmonary artery pressure, again, was decreased significantly in 5 out of these 6 patients. And you can see even the Borg scale was better after treatment with Selexipag as compared to before. So in conclusion, patients with disproportionate pulmonary hypertension in COPD and maybe in other chronic lung diseases, prescription of drugs like Selexipag in a carefully selected population can result in improvement of quality of life, improvement of 6-minute walk distance, and maybe a reduction of hospitalization. There's also reduction of pulmonary vascular resistance in this group of patients, and cardiac output and cardiac index were also better at follow-up. So why Selexipag? That's my last slide in my carry-home message. We know that pulmonary hypertension is an independent prognostic marker, not just in COPD, but all patients with chronic lung disease in group 3. Pulmonary hypertension in COPD is associated with increased risk of COPD progression and increased hospitalization and worse survival. Drugs which reduce pulmonary hypertension in patients with severe pulmonary hypertension and mild to moderate COPD reduces morbidity and mortality significantly as compared to placebo. The efficacy was consistent across all age groups, sexes, etiology, and background pulmonary hypertension therapy. The median duration of giving Selexipag was long, so the longer you manage to give the drug, the greater the benefit. And in this overlap group with disproportionate pulmonary hypertension, Selexipag resulted in improvement of functional capacity and cardiac parameters along with pulmonary vascular resistance. Thank you very much for listening to me. I'm sorry I've overshot time by a couple of minutes, but thank you. And thank you for making me a part of this meeting.
Dr. Prashant, you would continue? You would start now?
Yes, sir. I'll just share my slides. So first of all, good evening, everybody. And I would really like to thank MSN for organizing such a nice conference. And of course, to get Selexipag to India was one of the biggest things which we were looking at as for management of pulmonary hypertension, as Dr. Shastri has already told us. So in the next 15 minutes, what I'm going to talk about is what is congenital heart disease, what are the types of pulmonary hypertension we see in congenital heart disease, and what is the treatment of pulmonary hypertension associated with congenital heart disease. I don't have any disclosures. So congenital heart disease, as we all know, are the range of defects which are present right from birth, and they can arise from a combination of genetic and environmental causes. Global prevalence 1% of live births, and it affects up to 9 in every 1,000 babies born in India. So if we see the global distribution of congenital heart disease per 1 million population, you can see definitely India is at the forefront of, and the reason is manifold. One of them is being high prevalence of consanguineous marriages in our country. Broadly, congenital heart diseases, as we all know, can be classified as cyanotic and acyanotic. Acyanotic can be left to right shunt and off-flow tract obstructions, and the left to right shunt can be pre-tricuspid, that might mean before the tricuspid valve, that like an ASD or a PAPVC, and post-tricuspid means beyond the tricuspid valve, so like a ventricular septal defect, a PDA, AP window. These are all the ones which are post-tricuspid. Now, congenital heart disease and pulmonary hypertension can occur in group 1 pulmonary hypertension as well as group 2 pulmonary hypertension, which has already been stressed upon by Dr. Shastri. What we will be concentrating on is group 1 pulmonary hypertension. So these are the patients in which usually it is secondary to shunt lesions, which can either be the shunt lesion is already patent, that is, has gone into an Eisenmenger syndrome, or it is post-shunt closure, and I'll come to it later. So if you see the distribution of, so this was a status report which was published by Dr. Saxena et al. From All India Institute of Medical Sciences. And if you see the maximum prevalence of congenital heart disease is in the north and the east of the country. However, if you see the facilities which are available to treat this congenital heart disease, the programs which are available to treat congenital heart disease are pretty much concentrated in the south and to some extent in the west. However, the incidence is more towards the north and northeast part of the country. Things are improving slowly, but they are improving for sure. However, this problem, what it results in, a lot of patients who are either not operated for congenital heart disease, which results in them going into having congenital heart disease with PH, either Eisenmenger syndrome, or being operated late, so that they continue to have pulmonary hypertension even after the shunt is closed. So it's a common complication, as we have already seen, with uncorrected congenital heart disease, or it is corrected, which is things which are corrected late. So these are all the congenital heart disease which can cause pulmonary hypertension. What I would like to say is any patient who has got an increased flow, so either at the pre-tricuspid as well as the post-tricuspid, these are the ones which can cause pulmonary arterial hypertension, that is group 1 pulmonary hypertension. PH due to congenital heart disease can be divided into 4 groups. First group A is Eisenmenger syndrome. That means there is already a reversal of shunt. The patient already is cynosed. Pulmonary hypertension, which is associated with systemic to pulmonary shunt. So these are usually moderate to large shunts which have already resulted in pulmonary vascular disease. However, there is no reversal of shunt. The shunt is still left to right. The patient is still saturating more than 95-96% at rest. And these is form the group B pulmonary hypertension associated with congenital heart disease. Group C are more or less something like an idiopathic pulmonary hypertension with an incidental shunt. So you have a small ASD, a small VSD, or a small PDA, which you think that probably does not cause pulmonary hypertension, is probably not the primary cause for pulmonary hypertension. The primary cause of pulmonary hypertension may be something else. This form the group C, that is pulmonary hypertension with small defects. Group D, and this is a very, very important group in our country, in which the pulmonary hypertension persists after surgery. So now what happens if you close the VSD, PDA, AP window in time? In time, I mean it's less than usually approximately 3 to 6 months of age. There is usually no pulmonary hypertension which remains. Now, if you correct this pulmonary hypertension later in the age, more than 2 years, more than 3 years, more than 4 years of life, more often than not, the pulmonary hypertension persists, although in a more milder form. However, as the disease progresses, because we all know that pulmonary hypertension is a progressive disease, and as the disease progresses, these children become more and more sicker. So what are the treatment options available for congenital heart disease and PH? And we'll go into each of the groups. So first is the endothelin receptor antagonist. And this was the first trial, Breathe 5 trial, which was the first trial which was published, which suggested that the use of pulmonary vasodilators may be beneficial in patients with CHD-PH. So they had 54 patients in total included in the study, out of which 37 were treated with bosentan and 17 were controlled. And there was an increase in 6-minute walk test of 53 meters in the bosentan group, which was significant. The next medication which was tried for pulmonary hypertension, congenital heart disease was macitentan in the Seraphin trial. Overall, 742 patients were recruited, out of which 8.4% had congenital heart disease and pulmonary hypertension. And this study showed that it has mortality as well as the morbidity benefit. However, the results of the CHD-PH group are not separately analyzed in this study. Then coming to the phosphodiesterase 5 inhibitors, that is the sildenafil group, and this is a very good study which was published from China, in which it was a 12-week prospective open-label multicentric trial, in which 55 patients of congenital heart disease were included, and they were divided into 3 groups. That's the ASD, VSD, and the patent. So basically, they're looking at simple congenital heart disease and pulmonary hypertension. So there was an increase in the 6-minute walk test in these patients, and there was increase in an improvement in the functional class. However, there was not much change in the baseline saturation. So only in the atrial septal defect there was some improvement in the baseline saturation. There was no improvement in the VSD and the PDA group. The WHO functional class, Bog-Dyspnea scale, and the mean arterial pressure, mean pulmonary artery pressure remained the same across all the groups. Then coming to the prostacyclin analogs, so epoprostenol was the first medication which was tried for use in congenital heart disease PH, and this study was published way back in 1999 by Dr. Robin Bast et al., in which 20 patients with pulmonary hypertension associated with congenital heart disease were included. All these patients received injectable epoprostenol, so injectable prostacyclin analogs. There was lack of acute response. So if you can see in the table which is on the side, there was no change from baseline in the acute. By acute, they meant 6 to 8 weeks of giving the medication. However, once they reached a chronic dose, so more than 1 year of therapy, they started showing improvement. So their mean PA pressure decreased by 21%. The cardiac index and pulmonary vascular resistance also improved long term. Similarly, there was improvement in the NYHA functional class and exercise capacity of these patients. Next drug which was tested in congenital heart disease PH was treprostinil, and this study was published in Heart in 2018, in which 32 patients with congenital heart disease and PH with a mean age of 40 years, out of which 22 were Eisenmenger syndrome, 7 patients had pre-tricuspid, so atrial septal defect, and 15 had post-tricuspid. And the duration of the study was quite good. It was a 12-month study. And they showed that there is an improvement, significant improvement in the 6-minute walk test as well as the NT-proBNP of these patients, although each of the lesions were not separately analyzed. Coming to Selexipag for treatment of pulmonary hypertension in congenital heart disease. So as a part of Griffon study, patients who have undergone closure of the defect and has persistent pulmonary hypertension after closure were included in the group. So those are the only patients of CHD-PH which were included in the Griffon trial. So out of the total 700 odd patients, 110 were congenital heart disease PH which were corrected. 55 of them were post-atrial septal defect closure, 38 post-VSD closure, and 14 post-PDA closures. And the patients were randomized 1:1 to receive Selexipag or placebo. And during a 12-week titration period, the drug was initiated as has been described very nicely by Dr. Shastri as well as Dr. Rajadhar. It was initiated at 200 micrograms and it was titrated up titrated to the highest tolerated dose. There was no significant difference in the patients at the baseline in the patients who received placebo as well as the Selexipag. They were almost the same. The background therapy was almost the same in both the groups too. And the patients with Selexipag group had a better event-free survival as compared to the placebo group. So there was a definite reduction, almost 30% reduction, as has been shown in the overall trial, and the sub trial also shows similar findings in congenital heart and PH. Although the side effects were common, at least one side effect was seen in almost all the patients, and these are the side effects which were usually not very severe. However, 30% of the patients had at least one serious adverse events, and 8% of the patients who received Selexipag as well as the placebo discontinued the drug. So there was no significant difference over there. And most of the side effects were transient and they were mild, and it was not very difficult to manage them. So in Griffon study, Selexipag was found to improve the morbidity as well as mortality, which was consistent with the overall population, and Selexipag was well tolerated. However, you have to understand that only post-operative pulmonary hypertension were included in this study. Now, this is another study which was published very recently in International Journal of Cardiology, in which the observers or researchers looked at a wide variety of adult congenital heart disease. Between 2017 and 2019, 34 patients were included in the study, out of which 21 had Eisenmenger syndrome, and 11 patients had PH after shunt correction, and majority of the patients tolerated only low dosage with a median dose of approximately 400 micrograms twice daily. Patient characteristics, the majority of them were female with an age of around 46, and 21 patients, that is majority of the patients, had Eisenmenger syndrome. and most of the patients were in functional class 3 and 3 patients were in functional class 4. So event-free survival was in this study was seen much better with pH after defect correction as compared to pH with Eisenmenger. So basically, Eisenmenger syndrome, they did not tolerate the Selexipag well, and their event-free survival was also not that good as compared to pH after defect closure. So if you see the patients who continued Selexipag at least for 12 months, there were 21 patients, out of which there were 6 patients with Eisenmenger syndrome, 5 patients with pH after defect correction, and most of these patients got converted from intermediate to low risk category. Now, 2 patients who were Eisenmenger syndrome actually worsened. One patient went from a low risk category to the intermediate risk category, and one patient went from intermediate to high risk category, and 13 patients discontinued. So we have to realize that out of 34, 13 patients discontinued. So 33% patients discontinued the medication because of side effects. So over here also, what we can see is, as compared to Eisenmenger syndrome, pH after defect correction, there is a better tolerability and there is a more clinical benefit. Now, this is another small case series which has been recently published, which was looking at patients with CHD-PH, as a part of treat to close strategy, which I'm not a very big fan of. Anyways, was done over here. 1 patient with Eisenmenger syndrome with poor exercise capacity, and 2 patients there actually tried to transition from the parenteral prostanoids to a Selexipag. And they reported that there is improvement in the functional class in most patients as well as pulmonary hemodynamics, and none of the patients discontinued Selexipag due to the side effects. However, we have to remember that there were only 5 patients which were only 5 patients which were included in this case series. So what is our personal experience of use of prostacyclin in India? So we have in a PH clinic now 503 patients which are there. A detailed counseling of all the patients is done regarding various treatment modalities which are available in India and which can be imported. As Sir has rightly pointed out, Shastri has rightly pointed out, risk stratification is extremely important and it has to be done at each visit. So, and for that, we look mainly at the non-invasive parameters because we can't keep on doing the right heart cath at each visit. But symptoms, echocardiographic parameters, and basically looking at the right heart function rather than the right heart, than the pulmonary artery pressure is extremely important. 6-minute walk test and NT-proBNP. Now, if you see this patient, it's one of the example of this patient. Now, you see this NT-proBNP levels. Now, each of these levels is not very threatening. But what you can see here is when the patient first came to me, she was already on pulmonary vasodilators. So her NT-proBNP was not very high. It was 88.42. It dropped down to 68 over the next 6 months or a year. And then from there, there has been a gradual rise from 68 to 103, 163, and 202. Now, if I see a absolute value of 202, or even 163, I'm not really alarmed. But if you see the trend in this patient, there is a definite trend which can be seen from October 2020 to Jan 2022. And I'm sure if I remain like this and not do anything at this point in time, the patient may probably go into the right heart failure. And then it might be very, very difficult to treat this patient. So it's always important that we do the risk stratification. We look at each and every parameter, at least the ones which are non-invasive and can be routinely followed up in our day-to-day practice. So we have started prostacyclin in 22 patients with inhaled iloprost, 5 patients with subcutaneous treprostinil, 7 patients we have treated with Selexipag, and 3 before it was available in India, and the 4 we have started in the last week or so. Our age group was from 3 to 56 years. 14 patients had CHD-PH out of the 31, I think, total. 12 patients had post-operative PH, and 2 patients had PH which was out of proportion to the congenital heart disease. So this is our youngest patient who is taking inhaled iloprost, and this is one of the patients in which we have started subcutaneous treprostinil by using the subcutaneous insulin pump. So our follow-up period is approximately 18 months. Iloprost dose was 2.5 to 5 micrograms 6 to 9 times daily. Treprostinil dose was 40 to 60, it should be nanograms actually, per kg per minute. Selexipag, we had a lot of trouble, and especially in the first 3 patients in we started Selexipag, and it's not probably because of the drug, but it is because of the strength of the medication which was available. Because when we had to import it, first of all, it was very costly. 1 month therapy was costing approximately 3 lakh rupees. And the cost of taking a 200 microgram tablet was same as taking a 1600 microgram tablet. So a patient tended to import a tablet which was at a higher strength. However, in one patient, we were able to reach 800 micrograms twice daily. The 2 of the patients were not able to tolerate the medications, and this, I think, was probably related more to the dosage which we had started rather than anything else. In iloprost and treprostinil, we did not have any major side effects which required withdrawal of medications. There was improvement in functional class and echo parameters, which allowed us to convert 2 patients to port shunt, and 1 patient underwent a heart-lung transplant. So this is our study which has been accepted for publication recently. We showed that there was improvement in 6-minute walk test. In most patients, there was a decrease in NT-proBNP. In all except 4 patients, similar improvement in echocardiographic findings. And here also in the echocardiographic findings, what we are more stressing on is looking at the right heart function. But what happens over long term? So this is one of our patients, and we then had 1 more patient after that. So the red arrow is the one when the patient was first referred to us in April 2015. It showed we started her. This was our first patient in which we started iloprost. You see the NT-proBNP is approximately 6,000 micrograms. There was picograms, sorry. And there was as soon as we started iloprost, she came from functional class 4 to functional class 2. There was a significant drop in the NT-proBNP level. And she remained in functional class 2 for approximately 2.5 years. And then slowly she started going from functional class 2 to functional class 3, and a similar in NT-proBNP. The yellow arrow, we went from 2.5 micrograms iloprost to 5 micrograms iloprost, but she continued to worsen, and then she again went into functional class 4. Here we thought that we should now refer her for a heart-lung transplant. However, she was not willing. So just did a little of a literature review, and we thought that why can't we change over to her a more potent prostacyclin analog, and here we started her on iloprost. Now she's in functional class 3, and there has been a significant drop in her NT-proBNP levels, and I hope the downward trend continues. To conclude, congenital heart disease is one of the most common underlying conditions for pulmonary arterial hypertension, especially the group 1 PH in our country. Use of prostacyclin analogs has shown to improve symptoms, 6-minute walk test, and pulmonary hemodynamics in patients with CHD-PH. Dose up titration and side effects of Selexipag is the biggest challenge, especially in patients with CHD. And future studies on specific subgroups of congenital heart disease, such as Eisenmenger Syndrome and single ventricular physiology, may guide its use in this population. Thank you.
Thank you, Dr. Prashant. It is very nice, including your personal experiences. You have done a wonderful job. Same with Rajazar. His presentation was excellent, very informative. I thank both the speakers in MSN. Now, probably, I think Dr. Thari is not there. We can take up the questions. Maybe I can't see any questions in chat box. You have got any questions there? Tanmay Mandal?
Yeah. Notuna, can you share the questions?
Yes, sir. Done in chat box.
Are they there? I can't see. That may be a separate chat box there.
Notuna, I can't see.
You read the questions, please.
Yes.
Can I ask a question before we go ahead? Shastri sir?
Yeah, go ahead. I don't see any questions. Somebody can read them out. We can take.
No,
Yes. How does Selexipag work with other prostacyclins such as iloprost and other treprostinil? Can this combination be used together?
Prashant has a lot of experience. Prashant?
No. Actually, we have to use either of them. We can't use both of them together. The only time when we use both of them together is when we are transitioning from one to the other. So when I'm transitioning from iloprost to treprostinil, I first go up slowly on the doses of treprostinil, and at the same time I'm coming down on iloprost. And a similar thing has been done with parenteral prostanoids and Selexipag when you're transitioning from parenteral prostanoids to Selexipag. So we can't use both of them at the same time in the therapeutic dosage.
See, one thing I should supplement here. Prashant is from financial capital of the country. He sees all Bollywood actors, industrialists, all big people who have got a lot of deep pockets. So, to import these drugs from abroad, as he mentioned, no, what is that, 3 lakhs per month, treprostinil? And that has to be taken lifelong. So for most of us, for most of the patients, many places, it is financially challenging and logistics is very difficult. Being stationed in Mumbai, he is able to do that. I think he works in Kokilaben Hospital, Ambani's.
Yes, sir. So one thing I would add here is, yes, the patients, we are lucky to have some patients who are really can afford this kind of medications. Otherwise, most of the patients wouldn't be able to afford the kind of financial resources which are required. But with increasing uses, the cost has come down. So when I first started iloprost in one of my patients, the cost was another 2 lakhs rupees. But today, iloprost is available at 20,000 rupees per month. Similar with treprostinil. So unfortunately, fortunately, treprostinil is manufactured in India, but they don't have the permission to sell in India. So out of the 5 patients, 3 of my patients have got treprostinil, which has been given by the Indian company through their CSR grants. And they are trying to help more such patients. So I hope that they'll be able to help more patients, and more patients will be able to benefit, because it's a drug which is manufactured in India by 2 Indian pharmaceutical companies. And unfortunately, our patients are not able to get the full benefit of it. We are trying our best, and let's hope that in the next 3 to 6 months they'll be able to support more such patients.
Yeah, one just simple word. We have Pulmonary Vascular Resistance India, PVRI, Pulmonary Vascular Research Institute, PVRI India. And I used to be very inert president for many years. Now dynamic Prashant has taken over. He's doing a lot of good work in getting these molecules and spreading the education research of this disease in this country. Prashant, all the best to you. Maybe you can take next question.
Yes, sir. Coming for the second question, does Selexipag shows better results when started earlier, that is just in the beginning of heart failure, or it can be taken at the later stages?
See, if you give earlier, the better. Once the heart failure sets in, generally patients in functional class 4, the relative benefit is less. In the pivotal Griffon study, hardly 1 or 2% of the patients are in class 4. Most are class 2 or class 3. Once the right ventricular remodeling, right ventricular failure starts and right ventricular remodeling occurs, fixed changes occur, the relative benefit is likely to be less. So you start early.
Okay. Coming for the next question, sir. Doses of Selexipag, whether it depends on the age?
No, it depends on individual tolerance. We do not know. There are patients who tolerate only 200 micrograms. There are patients, you saw one of the slides I projected, nearly 30-35% could tolerate up to 1600 micrograms BD. And from 200 to 1600, it varied any 10% L-COTS. So nothing to do with age. It's probably individual genetic makeup. As I mentioned, the prostaglandin side effects are very common. And 2 things are there. With the time, they get adjusted to it. So have patients, treat them symptomatically. Try not to withdraw from the treatment, and counsel them, reassure them. Half the time, the patient is more panicky about the side effects than side effects really being nuisance.
Okay, sir. Coming for the next question, did Selexipag can be given as combination therapy with ERA and PDE5 or triple drug?
Yes, it can be given. That is what the study showed. Many patients have already been on dual therapy background, dual combination therapy. So it can be triple drug. Yes, you should give. See, more you should understand one thing. Hypertension, the pulmonary hypertension behaves something like both essential hypertension and cancer. You treat these patients not with one drug. Many cancer therapies have a combination of drugs. Same with hypertension. Those are the physicians who treat adult hypertension. We end up giving 4 or 5 drugs also sometimes, starting from 1 to 5. So your objective is to bring down the pressure. Now that is one aspect. So you give combination therapy, don't feel shy. It's not that you stop sildenafil and start Selexipag or stop Mesetantan and start something else. It's not like that. You add. And normal systolic pressure, normal PA or pulmonary arterial pressures are 25/12 with mean of 18. So a patient having a 60 millimeters of systolic pressure is actually having 3 times the normal pressure. That if you convert to left side pressures, 120 millimeters of mercury of normal pressure, imagine 3 times, 360 millimeters. It can't tolerate left ventricle. The poor right ventricle can't tolerate so much pressure. So you bring down the pressure as much as possible, bring down the pulmonary vascularizations as much as possible. Except in a small minority of patients, these pressures don't become normal. If the pressures are coming down while on treatment, most likely cause is echocardiography has limitations and TR that is not well seen. So don't be very happy that the pressures has been coming down. Many times I see patients. Last time we did echo, it was 80 millimeters. This time it is 78 millimeters. They won't make sense. You see a gross functional status, RV function, and the RV systolic pressures as estimated on echocardiography are not reliable. So in nutshell, coming back to the question, the simple answer is go ahead and give triple combination if the patient's systolic pressures are high or patient has late function class 2 or 3.
Okay, sir. Coming for the next question, in PH associated with congenital heart disease, what all other medications can be recommended?
So we are using a dual combination therapy of phosphodiesterase 5 inhibitors and endothelin receptor antagonist wherever it is indicated. And Selexipag can be, or any other prostacyclin analogs can be used as a add-on therapy. The problem with Eisenmenger syndrome and Selexipag, I think, is more to do with the tolerance of the side effects. And as sir mentioned that the side effects are quite a lot, especially in Eisenmenger syndrome, because they have so many other comorbidities, other post-operative PH, they don't have cyanosis, they don't have hemoglobin, which is high, they don't have liver dysfunction, which Eisenmenger syndrome tend to have. So they kind of don't tolerate Selexipag, at least as of now, what has been shown is they may not tolerate Selexipag as much. But yes, we do use combination therapies in CHD-PH as well.
Okay, sir. Coming for the next question, can Selexipag to be taken by those who have undergone a port shunt procedure?
Yes. So normally the indication of doing port shunt in these patients is because there is severe right ventricular dysfunction, and we have done 21 such patients in which we have done port shunt. Now, what happens after doing port shunt is there is improvement in right ventricular function, and actually the requirement of medications may go down. In fact, the original study, which was published by Bardo et al., they showed that they were able to taper off the parenteral prostanoids, and that was one of the highlights of that study, in which they showed that you could take off parenteral prostanoids because the patient became symptomatically better, the RV function improved. Similarly, in our study also, what we saw that we were able to come down on, so we started some patients on prostacyclin, did the port, there was improvement in the right heart function, we did the port shunt, and then we took off the prostacyclin analogs. So yes, but if there is a deterioration again in the functional class, deterioration again in the right heart function, sometime after doing port shunt, we may be able to start these patients on Selexipag. However, we need to be cautious and we need to probably go very slow on the dosage, because they would then behave like an Eisenmenger syndrome with pulmonary hypertension.
One word of caution here, Prashant has been mentioning about port shunt for severe pulmonary arterial hypertension. I hope the questionnaire is not getting confused with the port shunt done in tetralogy of Fallot. So that's very important. Port shunt is in these patients is different.
Coming for the next question, sir, did Selexipag can recommended in CTPH group 4?
Well, there are no clinical trials to my knowledge. The only drugs which have been shown to be beneficial is Riociguat and some evidence for macitentan, but not really much. In a desperation, we give. Patients feel better. In a randomized control trial, only Riociguat has been shown to be beneficial. But I don't think we have an answer whether Selexipag can be given. The treatment for thromboembolic pulmonary hypertension is surgery, surgery, surgery. If one surgeon cannot do it, send it to second surgeon or third surgeon, or consider balloon angioplasty if the patient can afford and if you can do it. Medical management of CTPH is not a correct decision in first choice, but if you're desperate, you give. The clinical trial answer is not there.
Okay. Is there any severe side effect after using Selexipag?
Nothing like severe side effect. There is no serious adverse events are not there. It is more of a nuisance side effects. Headache, jaw pain, they are transient. They come and go. They'll be irritating. Imagine somebody having continuous jaw pain, headache, diarrhea, flushing. This kind of headaches. They're not serious. Actually, if you see the clinical trial, the serious adverse events are less in Selexipag than in placebo group. So I don't, to my knowledge, there is no serious side effect with Selexipag. It's only more of a mild nuisance background side effects.
Okay, sir. Did Selexipag given as a monotherapy if patient came with he has diagnosed with a pulmonary arterial hypertension for a new patient?
You can give, no problem. That is what the study showed. But first, don't frighten the patient and drive him away. First, start with sildenafil or tadalafil and macitentan or bosentan. Then add. Patient will stabilize and do better. Theoretically, you can give, no problem.
Did Selexipag recommended for high-risk PH patients which are in functional class 4?
It is not recommended, but in a country like India, you have no choice. So you do something and you try to do something. Only recommendation, class 1 recommendation for class 4 patients is continuous intravenous infusion of epoprostenol. Maybe Prashant Mumbaites can give it, but most of the rest of the country cannot give.
Any other future recommendations for pulmonary arterial hypertension in a treatment options?
difficult to predict future.
That's it, sir. Apart from it, nothing.
Great, thanks.
Thank you.
So,
What do you, Tanmay?
yeah. Thank you so much, sir. First, I take pleasure to thanking you, Dr. Sastry, Dr. Prashant, and Dr. Raja sir also, and all the participants attending this program to taking out your valuable time and enlightening the audience on the pulmonary arterial hypertension and the therapy and this the Selexipag. Second is that Dr. Prashant and Sastry you were talking about the cost barrier of this molecule. When you have used this molecule, that it was very expensive for the Indian patient considered. So MSN has a motto to bringing down the Indian patient suffering by bringing the newer therapy to the Indian market with an affordable way, so that the each and every Indian can be use this molecule. So the same molecules what you are talking about, the Selexifag, we have launched to the Indian market for the first oral prostacyclin receptor agonist to delay the progression of the pulmonary arterial hypertension, that is WHO group 1. The brand name is Selepeg. It is available in 2 different strains, sir, 200 and 400. And along with our existing pulmonary arterial hypertension management product like the Pulmonix, PH20, Selexipag, sildenafil, then Pulmonix kit with the tadalafil, with ambrisentan, tadovaz, macitentan, and Riociguat. Sir, we may be the youngest player, but our drive and enthusiasm are the best in associating with you in the management or the bringing down the Indian patient suffering for the pulmonary arterial hypertension. So I had to say the thank you to all and all the participants.
Dr. Mandal, can I make a quick request, if you don't mind?
Yeah, tell me, sir.
not necessarily to MSN. Of course, MSN also can take the request. On behalf of the PVRI or individually on my behalf, physician interested in pulmonary hypertension, having seen this for so many years now, I see many patients who can't afford even simple drugs. Not necessarily, I'm not talking about prostaglandins or Selexipag. India is 85% of the patients are really poor. We can't help it. My only request is anybody who has got good political connections among the audience sitting here and still listening, if you can connect to Ayushman Bharat or some of the state government health schemes and make this medicine package as a part of the monthly treatment, that will help many patients. For example, if for surgical procedure, they sanction 1 lakh and the patient can get nearly 20 months treatment of these drugs. So my appeal, because I don't have any political connections, if anybody among the audience has political connections, please request the concerned health authorities of the nation or the respective states if they can include this in the public health distribution. Tamil Nadu, for example, in the government hospitals, I understand they give PAH medication, but Selexipag and all these other medicines should be available all over the country. Thank you.
We have brought this medicine, the Selexipag, the 84 rupees per tablet for 200 mg, and for 400 it is 15 rupees 90 paise. That we have done today in patients.
Great, thanks.
So, thank you so much, sir, once again. Thank you, Satsi sir, Prasant sir, and all the audience. Good night.
Good night.
Thank you very much, sir. Thank you.
Thank you.
Good night.
You can close out the link.